Transunder patch enlargement of right ventricular outflow tract. When the right ventricular outflow tract obstruction is due to a diffuse hypoplasia involving the infundibulary chamber and the pulmonary valve ring, a transunder patch may be required. The annulus is sized with Haggard dilators. If the diameter is more than 2 standard deviations below the mean normal value established by Rowlett et al., as shown in table 28.1, a transunder patch is inserted. The patch may be fashioned from pericardium or from prosthetic material, Dacron or Gore-Tex. It should be oval, diamond-shaped patches increase the risk of stenosis at the end of the patch. The original incision in the pulmonary artery is extended inferior across the pulmonary valve ring. The pulmonary valve is at least partially excised anteriorly. The posterior cusp might be left in situ if they are not obstructive. The patch is positioned starting the suturing with a mattress suture at the most cephaled end of the incision. 6-0 polypropylene sutures for neonates and small infants, 5-0 in older children. The suturing then continues with a running over and over suture, placing the first 2 or 3 bites along each side before pulling the pericardial patch into position as the suture is tightened. Suturing is continued on each side of the pulmonary artery and then on the right ventriculotomy. Now in this left figure 28.9, you will see that the incision should not be diamond shaped, it should be oval, not to have stenosis. Then you will see how they began to sew it, and then the end of the picture. Ventriculotomy incision, taking deep bites into the muscles. This part of the operation can be performed on the beating heart while rewarming the patient. If air has been completely evacuated from the left side of the heart and if there is no residual communication between the two atria. Before completing suturing in the patch, the right ventricular outflow tract is re-inspected to ascertain that the size is still adequate after the heart muscle has regained tone. Monocast patches fashioned from homographs or pericardium have been used. Recently, Gore-Tex has been recommended to minimize postoperative pulmonary regurgitation. The insertion of a homograph Unicast patch is illustrated in figure 28.10. In placing the patch, it is important to position the valve at the same level as the posterior leaflet of the patient's own valve cusp for optimal effect. Usefulness of this valve patch remains controversial. If it were considered that a competent pulmonary valve was required, we would use an aortic or a pulmonary homograph. In the presence of pulmonary hypertension, a porcine valve Dacron conduit may be preferable. Similarly, poor right ventricular function, tricuspid valve incompetence, and small right ventricular cavity are other indications for pulmonary valve insertion at the time of right ventricular outflow tract reconstruction. This may consist of an orthotopic pulmonary valve replacement or the interposition of a homograph between the right ventricle and the pulmonary artery. Pulmonary valve replacement using homograph interposition, but before it we can see the homograph with Unicast. Pulmonary valve replacement using homograph interposition. The pulmonary artery is dissected from the ascending aorta. If the main pulmonary artery and the pulmonary annulus are very hypoplastic, further dissection is necessary. The pulmonary artery branches are fully mobilized down to the hilum on both sides, and the ligamentum arteriosum is doubly ligated and divided. A full mobilization of the pulmonary arteries will permit the use of a short homograph without the need for prosthetic material extension. The pulmonary artery is transected upstream to the bifurcation. The opening might need to be extended into the proximal right and or left pulmonary arteries to match the diameter of the homograph. The homograph is tailored to the appropriate length, allowing for the heart regaining its tone after the release of the aortic clamp, and the distal anastomosis is made with a running 5-0 or 6-0 polypropylene suture. The proximal anastomosis is then carried out, starting the suturing posteriorly on the superior margin of the right ventriculotomy incision in case of pulmonary atresia, or on the posterior aspect of the pulmonary valve ring. This is usually done with a 5-0 or 4-0 polypropylene suture. The suture is continued from the midline along both sides around half of the circumference of the conduit. If the conduit is an aortic homograph, the anterior leaflet of the mitral valve may sometimes be used as an onlay patch to complete the insertion of the conduit to the right ventricle. On the other hand, the mitral valve leaflet may be resected, as this would give the aortic homograph a more natural curve. Whenever possible, we try to avoid extensions of this homograph conduits with autologous pericardium because of aneurysmal dilatation of the patch over time. When the hypoplasia of the pulmonary artery extends to its bifurcation and the origin of both the right and left pulmonary arteries, a long pulmonary artery homograph taken with its bifurcation can be anastomosed to the transected right and left pulmonary arteries and to the right ventriculotomy. A patch of pericardium, patient's own or bovine or prosthetic material, is cut to a semilunar shape and is sutured between the homograph and the margin of the right ventriculotomy. Figure 28.11. The exposure is sometimes facilitated by a transection of the ascending aorta. In our experience, this is rarely necessary after ample mobilization of the aorta and the pulmonary arteries. Repair of supravalvular pulmonary stenosis. Stenosis of the origin of the left pulmonary artery is dealt with by extending the incision from the main pulmonary artery well beyond the obstruction. Stenosis of the origin of the right pulmonary artery is more difficult to repair. The incision must extend from the main pulmonary artery well across the stenosis. Adequate mobilization of the ascending aorta usually permits a good exposure of the origin of the right pulmonary artery. Stenosis of the pulmonary artery bifurcation is usually dealt with by extending the incision from the main pulmonary artery well into both the left and the right pulmonary arteries. It is often difficult to tailor a rather complex T-shaped patch to the appropriate size. Here the stenosis of the right. First, this is the left pulmonary artery stenosis, and this is the right pulmonary artery stenosis. This is the both pulmonary artery stenosis, and it may be easy to use two patches. A rectangular patch is utilized to widen the right and left pulmonary arteries, and the second patch to widen the main pulmonary artery, as shown in figure 28.30. Cooperation with an interventional cardiologist is essential. He/she may be able to relieve some of these obstructions by balloon dilatation or stenting if indicated.